Hello, and welcome to this presentation, Unlicensed Staff Caring for Older Adults in Long-Term Care During the Pandemic. My name is Carol Long, and I'm pleased today to share with you information about this most important topic. One thing that I didn't know is that recently the United States Bureau of Labor Statistics identified that over 1.5 million jobs are held by CNAs in the United States, not to mention all the other people listed on this slide that are providing unlicensed personal care services in a variety of settings, such as nursing care facilities, hospitals, continuing care communities, residential care, assisted living, home health, hospice, and more. So many people are providing unlicensed care in these long-term care settings. It's so important to get this information to them. You know, each of you have different work responsibilities. Many of you provide direct care to people who live in these communities, and many will help older adults in the days and hours approaching death. You have a significant, important role to learn about COVID-19 pandemic and the role that you play in hospice or palliative care for older adults and the person who is dying. So let's get started. We have 4 objectives for today's session. And the first is to describe the current pandemic and the risks for older adults and those living in long-term care settings, to identify palliative care needs for these individuals and your role in working in these settings, to describe the importance of communication and ways to augment care practices that support physical, psychosocial, and spiritual well-being, and then to discuss goals of care and care at the time of death. Okay, SARS-CoV-2, or the novel coronavirus, COVID-19, was first detected in Wuhan, China in December 2019. According to Johns Hopkins, over 7 million cases have been reported globally and 2 million in the United States, with over 28,000 deaths in nursing homes for residents and staff members. The primary symptoms of COVID-19 will be discussed shortly, but we do know that current mitigation efforts and prevention measures such as social distancing, wearing face coverings, good respiratory hygiene, and hand washing have been the mainstay advice to control the fast rate of spread. Some people have minor manifestations of the disease, while others will succumb to the overwhelming infection. To date, hospitalization rates and mortality in the United States have been highest among adults aged 65 years and age and older, and generally the oldest old, and those living in long-term care facilities, particularly nursing homes, and those with underlying conditions that include hypertension, obesity, chronic lung disease or asthma, diabetes, and cardiovascular disease. Particularly, these conditions are not well controlled. Other at-risk patients include those who are immunocompromised, such as those under cancer treatment, post-transplantation, prolonged use of steroids or other immune weakening conditions. And these all lead to what is called a cytokine storm. Ultimately, these situations, if the person's unable to recover, will result in sepsis, multi-organ failure, and death. In fact, many factors predispose older adults to coronavirus, but older adults, the group most at risk for complications or death, may not have some of the characteristics as described, as they may not present the same way as younger individuals. Older adults may reside in long-term care settings such as nurse facilities and non-nursing home settings such as assisted living, continuing care, retirement communities, or residential care homes. They are particularly vulnerable for an infectious disease outbreak such as COVID-19. The U.S. and other countries have witnessed a surge in the number of facilities and people who have tested positive, became seriously ill, and died from the virus. In fact, the most vulnerable adults live in the most vulnerable places, nursing homes. Long-term care facilities are largely congregate or communal settings where residents gather for mealtime and social activities. People often gather in lounges to play cards or engage in facility-sponsored events. Residents' rooms may be private, semi-private, or shared space with 3 or more individuals. The National Disaster Recovery Framework from Homeland Security identifies infection control measures, which include prevention measures such as hand washing, cough control, social distancing, and so forth, protective measures or preparedness, such as temperature monitoring with screening questions, mitigation, identifying who, staff, resident, or vendors is contagious, securing adequate testing and access to personal protective equipment, and recovery, which is currently in progress, I hope, at this time, even as new cases are discovered and deaths continue with ongoing monitoring of trends. The pandemic management has truly been challenging for all of us. Long-term care facilities face multiple potential scenarios to meet resident care needs during this time. If a facility cannot manage an infection or the person becomes ill and is suspected to have the virus or test positive, the resident may need to transfer to a different location within the facility for isolation and quarantine, or transfer to a different facility, such as a COVID-19 long-term care facility for isolation and treatment, to a hospital for isolation or aggressive acute care, or to hospice within the facility or inpatient setting, if these care settings are available for the person who's dying. And of course, these situations are different across the country. Without testing, others may succumb before transferring out. Still, other older adults may return back to the facility or elsewhere for continuing rehabilitation after hospitalization. The status of these transfers continue to be in flux, and day by day, these situations truly change. Finally, the pandemic situation remains fluid, and many resources are available for hospice, palliative care teams, and long-term care facilities to keep current with updated resources on COVID-19. State and government officials, along with scientists and the CDC, continue to monitor all aspects of the virus in addition to the outbreaks, specifically in nursing homes. Working with palliative care and hospice teams will be one of the responsibilities that you'll be significant part of your job responsibilities. For some older adults with COVID-19, the downhill trajectory may be slow. For others, a prolonged decline, and for those with emergent status, the death may be sudden and quite unexpected. Palliative care or hospice teams can help unlicensed care staff care for older adults who are experiencing serious or life-threatening illness, such as the virus. The goal of palliative care is to prevent and relieve suffering and to support the best possible quality of life for patients and their families, regardless of the stage of the disease or the need for other therapies. Its goal is to enhance quality of life for residents with serious illness and family members, and medical care can be rendered along with life-prolonging treatment or as the main focus of care. Palliative care began in the hospice movement. Hospice care is a delivery system that provides palliative care for patients or residents who have a limited life expectancy, typically 6 months or less, and requires comprehensive biomedical, psychosocial, spiritual support as they enter the terminal stage of an infection or condition. Hospice care provides support to the individual through the dying process and the surviving family through dying and bereavement journey. Access to and the provision of palliative care and for people in long-term care settings and during this pandemic is extremely important for those with the virus or older adults with other medical conditions in which the person has become seriously ill or is dying. It is essential for these teams to collaborate with professional and all staff in nursing facilities and residential communities to assure that the person and resident care is safe, effective, and person-centered. Long-term care facilities are on high alert to ensure both safety of staff and residents throughout the organization in this infectious disease outbreak. During the pandemic, the move to lock down the facility has been unprecedented, as the rapid acceleration of virus spread has left both staff and residents in compromised situations. So optimizing care has been extraordinarily important. Shifting to prescribed mitigation strategies are augmented by isolating residents to their rooms, leading to reduced personal contact with staff, family, and friends. Medical and other supportive care may have to be delivered by telehealth services, and practical solutions to assure safety while normalizing the usual activities of daily living may lead to stress and uncertainty for staff and residents alike. Patients already on hospice and palliative care services are particularly vulnerable due to their compromised health and possible decrease in supportive services. While the federal government has granted leniency in hospice and palliative care team members entering the facility for compassionate care, the rigorous measures to assure safety for all remains paramount. including, as you know, temperature checks, face masks, and the like. In fact, one has to consider the gowns, gloves, and masks may be very frightening to older adults, and particularly those with dementia. Regardless, for many, palliative care approaches are fundamental for all residents during the pandemic due to pre-existing medical conditions and increased vulnerability in this time. So what are some of the palliative care approaches we must consider, and what's important? Actually, there's no one that spends as much time at the bedside with older adults in long-term care settings than do you, providing personal care to them. You are often the eyes and ears of professional licensed care staff. Professional interdisciplinary team members, residents, and families alike depend upon you to care for individuals, to report changes in their condition to nursing staff. The pandemic is like none other, challenging all long-term care staff to be safe for themselves while executing exemplary care for the residents who are all at risk. Palliative care mitigates symptoms and provides comfort, particularly in an acute and changing condition for the older adult with COVID-19 or others who are dying. Excellent communication is necessary to support quality of life for the older adult. And remember that all care is person-centered. Communication is complex, but it is the foundation of excellent palliative care. What we know is that advocacy and assuring the best interest of the older adult and family is an essential ingredient in effective communication. Older adults have expressed what is important to them related to communication and their greatest fears, such as the need for information during uncertain times, the opportunity to disclose feelings such as sadness, loneliness, and to maintain a sense of control during uncertainty, and to be hopeful when things can be so disruptive and so many barriers can evolve. There is no I in team, and palliative care for older adults and long-term care is truly team care or teamwork. Strong communication and collaboration between the interdisciplinary team members to address the physical, psychosocial, spiritual, ethical, legal concerns and care at the end of life is truly necessary. Working under the supervision of a nurse and in partnership with other team members, unlicensed care staff can implement the plan of care. So what do we know about all of this communication? Well, based on the expectations expressed by patients, older adults, and families experiencing life-limiting illnesses and diseases, it's important to communicate that, first, you will be respectful of them. You'll be honest and truthful during times of crisis. You will work with the entire interdisciplinary team and see what they understand the care plan and how they communicate the goals of care to one another. You will listen with unconditional acceptance. And older adults and families very much need to know that you will be with them during this time, not just physically, but emotionally as well. There are numerous barriers to effective communication that have been identified. What else can you do? Well, first is to recognize and support individuality and personhood. The person you know best is the person you are caring for. So understand the impact of the pandemic or life-threatening emergency during this time. Respect and honor culture in all communication and preferences. Understand and support expectations of older adults and the person you are caring for. Convey compassion, express empathy, listen attentively, and be mindful in all interactions. This is what best supports excellent palliative care communication within the long-term care team. Older adults may or may not become ill with coronavirus. The physical symptoms may be non-existent or insidious for others, progress rapidly, necessitating maximum care planning for a severe illness situation. First, monitor for the primary symptoms, report them to licensed nursing personnel, and I'll review those in a moment. Be mindful of emergency situations, such as an individual having trouble breathing, persistent chest pain or pressure, new confusion or inability to arouse, and bluish lips or face, or what we call cyanosis. They may just become lethargic and remain afebrile without the initial respiratory symptoms. and exhibit signs of delirium while still decompensating, when in fact it is the virus. Others may just not look the way they usually are. In all cases, report any physical findings or changes in sensorium to the nursing staff for continuing follow-up assessment and planning. Older adults in long-term care may be on palliative care or hospice already, or become patients over the time of the pandemic. Those people who are already compromised will have a greater risk of virus, so be mindful of any sudden change in the resident's condition that requires further assessment. When we think of pain and symptom management, several considerations are evident. One important aspect of this role is observing for and reporting pain. Although you do not assess pain or give medication directly, you are a valuable team member whose job is to report and document your observation of the resident's comfort. Always ask older adults to report distressing symptoms, particularly new problems that emerge that may be indicative of a changing physical or mental status. Monitoring for unforeseen decline and exacerbation of clinical conditions or new geriatric symptoms require astute observation and interventions. So geriatric conditions include things such as new urinary incontinence, or a person who starts falling, or a new delirium, weight loss, or sleep problems. This might be indicative of an underlying problem that's going on. Unlicensed care staff observe and report to other team members, usually the nurse, when the patients have end-of-life symptoms including pain, anxiety, and shortness of breath. You also report and observe the effectiveness and side effects of therapies, such as medications, provide non-drug treatments as prescribed. Finally, interventions for older adults may include medications, but always include non-drug treatments to meet comfort needs. Let's review the primary symptoms in greater detail. Unlicensed care staff need to be on the lookout for primary symptoms of COVID-19 and any other change in conditions that are not attributed to the pandemic. People with COVID-19 have had a variety and a wide range of symptoms reported, ranging from mild symptoms to severe illness. People with these symptoms or combinations of symptoms may have cough and shortness of breath or difficulty breathing, fever, pain, generally muscle aches or a headache, sore throat, chills, repeated shaking with chills, and new loss of taste or smell, usually 2 to 14 days after exposure. Interventions for pain and symptoms necessitate pharmacologic and or non-pharmacologic or non-drug interventions. Unlicensed care staff will report observations and characteristics of symptoms, observe and report side effects of medications, and deliver these treatments under the direction of the nursing staff. Older adults report shortness of breath or difficulty breathing, or a new cough may be exhibiting signs and symptoms of the virus. A cough is triggered by shortness of breath and is often dry and persistent. Like shortness of breath, cough is often physically wearing, so be mindful of any fatigue and notify the nursing team. At a minimum, residents should be asked to rate the degree of shortness of breath or coughing on a 0 to 10 scale, ranging from 0, no shortness of breath or cough, to 10, which is the most severe. Other assessment tools are used for people who cannot self-report. Individuals may receive oxygen by nasal cannula, particularly if they've shown a reduction in oxygen saturation. And unlicensed care staff will need to monitor accuracy and usage. Medications may be administered, and care staff can observe and report effectiveness. Fever and pain are two other significant findings. It's important to report to staff fever and any or pain that your resident is experiencing. Fever for older adults is identified as a signal temperature over 100 degrees Fahrenheit, or 2 oral repeated temperatures over 99 degrees, or an increase in temperature of 2 degrees Fahrenheit over the baseline temperature. These are new findings through the pandemic efforts. Older adults will respond well to acetaminophen or Tylenol to reduce fever. Pain is a subjective experience and defined by the individual, so self-report is key. At a minimum, residents should be asked to rate the degree of pain, also on a numeric rating scale, 0 to 10 or 0 to 11 point scale, ranging from 0 to 10, which is most severe. You can also ask other things like, what's the pattern of pain? Is it increasing or decreasing? Where is the pain? These other things can be asked and should be addressed by the nursing team. Other assessment tools are used for people who cannot self-report, such as a person with dementia. For patients with mild pain related to headache or body aches or sore throat, muscle pain, or continuing chronic persistent pain, acetaminophen can be helpful. Individuals with increasing or unrelieved pain may receive other analgesics such as morphine for pain relief. It'll be important for unlicensed care staff to monitor effectiveness closely and to monitor patterns of pain, resolution, other complaints, and any side effects from medications and report them to licensed nursing staff. Non-pharmacologic or non-direct interventions can be used. Consider relaxation techniques, soft music, hymns, prayers, and other physical modalities such as repositioning and massage in a calm environment. Cool washcloths may be helpful for older adults with fever. Finally, continue to observe for all COVID-19 symptoms and others that are significant end of life, including but not limited to increasing fatigue, delirium, anxiety, depression, and gastrointestinal problems. What about psychological and social aspects of care? Well, the lockdown in nursing facilities and other long-term care organizations starting in March has left older adults living in these facilities isolated from the world and separated from family members and friends who are unable to visit. Additional physical barriers include no congregation in activity rooms or dining rooms, resident doors are shut generally, and physical distancing is in place. Engagement in activities throughout the facility fell by the wayside, and physical distancing became the norm, which may have generated feelings of loss and even confusion for some people. Communication be less, and staff wearing face masks and other personal protective equipment create a great sense of distancing, except for the necessity of personal care activities and mealtime. The emotional responses are devastating. They may include manifestations of fear, loneliness, depression, and complicated grief. And this may be seen in a person's dietary changes, withdrawal, sleep disturbances, anxiety, confusion, and more. So what can we do about psychological and social interventions? Well, it's extremely important to improve communication, and that means regular observation and engagement in communication with our older adults. As such, unlicensed care staff will need to monitor residents and inquire about their health status, and it's going to be more than just asking how a person's doing. It's going to be more like, how should we start our day, or what activities would you like to do, and how are you feeling today, but be really specific in what you're looking for. Also conduct routine, at least hourly, resident rounds to assure safety. Inquire regularly about their physical status and symptoms suggested of the virus. Notice any change in the resident's condition. Empathic listening, telling residents that you will keep them safe, and demonstrating genuine interest in caring throughout the day is extremely important. What about activities? Well, the backbone of long-term care includes 6 activities of daily living plus all the social activities. It's important to monitor any decline because of the less participation of these individuals in ADLs or in other activities in the facility. We also need to be mindful that activities are just not a way of doing things for people, dressing them, grooming them, etc. It's a way to actually connect, inspire, and bring joy in the simplest of ways. Genuine, meaningful connections are essential. Every activity should be a meaningful connection, so don't waste these opportunities to make that continuing connection with your residents. The pandemic, residents may or may not become aware of the urgency surrounding their health and security, except their routines are severely disruptive and implications related to their own health and mortality may become a conscious concern. Spirituality refers to the aspect of humanity that refers to the way individuals or residents seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature and to the significant or sacred, and what a trying time this pandemic has been for them and all of us. Spiritual apprehensions and distress might arise as older adults become aware of the possibility of their own death, and more so for people they may be dealing with a serious illness, unable to be with family members, or have been diagnosed with a recent terminal condition. These many losses and fears can extend into people's spiritual lives and cause spiritual distress. Be mindful of the residents' personal, spiritual, or religious beliefs, rituals, and practices, and recognize and identify factors contributing to distress. Report any concerns to the nursing and interdisciplinary team at the facility, palliative care, or hospice. And what about spirituality interventions? Well, probably most important is to assure therapeutic presence. The process of being with a person, both physically and emotionally. It involves active listening and willingness to let the person take the lead in the encounter. It's more about being with than doing. This can be done by validating the older adult's feelings for what they are. Promote hope. The feeling of pain and suffering is real. Establish a trusting relationship with this person and find pleasure in every day. Remain non-judgmental and listen. Take care not to judge or attempt to solve the problem and accept them. Be respectful and supportive of the older adult and family by accepting them. Be present in the moment, which can help relieve suffering and bring peace at this time, and particularly for individuals at end of life. Supporting families of residents in long-term care is extremely important. Family members may be in turmoil and the family unit in jeopardy during the COVID-19 pandemic. Social distancing is largely exclusion from the facility may cause stress and uncertainty for their loved one. Family members should list their expectations regarding communication and care for their family member during the pandemic. The best move is to think, overprotect, and not overreact. Greater vigilance is expected in nursing homes due to the number of facilities and residents affected. You should be able to be astute to family and resident concerns and let nursing staff know, and try to be attentive and aware of changing circumstances all the time. One way that advocacy is manifested is in advanced care planning, and your role as an advocate is important. For residents who are on palliative care or hospice, assure that family members can visit and all precautions are available to protect them and their family members. Finally, not all residents have clarity or have developed their advanced directives. Residents often share their goals of care, dreams, and hopes with unlicensed care staff. When you hear older adults and families talk about these issues, be sure to encourage them to express their thoughts to the doctor and other team members. What else can you do to support families of residents in long-term care? Well, one way is to plan ahead. It's important to plan ahead if the person is transferred out and if they do not come back to the long-term care setting due to a change in condition that necessitates a different setting for care. Prepare a favorite items bag based on what the resident enjoys and needs. Solidify communication strategies on who will be involved and what will happen with the disciplinary team. Maintain hope. Families need to have hope as long as the dying person is present. Do not think of hope as a form of denial of reality. Hopefulness can coexist with knowledge that recovery or longevity is not a realistic goal. And messages to the dying. When the person is ready to die and the family is able to let go, saying goodbye is a final gift of love. If family members are able to communicate with their loved one during the final days, there may be an opportunity to speak of gratitude, forgiveness, unconditional love, and final goodbyes and letting go. Finally, find ways to support family, including measures in self-care and ways to focus on what they can control at this time. What we know right now is a lot of unknown, and it is unknown how many residents have died, residents and actually staff members have died in nursing facilities and assisted living facilities during COVID-19. We do know that in 2017, 31.8% of deaths, or close to 350,000 of the 1.1 million beneficiaries received hospice care, died in a nursing home. It will be some time before we know the final outcome related to deaths in a nursing home or other long-term care facilities related to the specific pandemic. Dying is a sacred journey for older adults at the end of life. The entire long-term care team needs to assume a person-centered care approach at the end of life in the quest for a good death, meeting the person where they are at, and assuring that their needs are met during the sacred time. Unlicensed care staff roles at the end of life are many, and they're extremely important to establish daily priorities as the older adult's condition changes, to create a comfortable physical environment for the older adult and family, to get personal care that maintains the older adult's comfort and dignity, to observe and report symptoms that occur at the end of life, to provide emotional and physical support to older adults and families. It's so important, and to provide care that's consistent with the wishes and values of both the resident and family, and providing care at the time of the death event. Unlicensed care staff look for signs that death is nearing with other team members, help prepare the family. They also prepare the body after death. They need to provide post-mortem care in a way that is respectful of the resident patient family cultural and spiritual traditions. Finally, it's important to know the signs of death that have occurred. Absence of respirations or lung sounds, absence of a heartbeat or pulse, lack of response to any verbal or tactile stimuli, fixed pupils and the eyes may remain open, pale and waxen skin, a drop in body temperature, muscles and sphincters may relax, the jaw may fall open, and a release of stool and urine may occur. Again, after the death has occurred, bereavement support will be initiated by providing compassion, active listening, and presence. Be sure to inquire about family and presences for aftercare of the deceased and preferences of the body. Leave the body in a peaceful and respectful position. The drastic changes that our society has undergone and ever-evolving uncertainty can affect the heart and soul of caregivers in long-term care settings. The suddenness of the pandemic and risks assumed by licensed and unlicensed nursing care staff and the interdisciplinary team has taken a human toll in both their personal and professional lives. Proactive self-care and the ability to bounce back, which we call resilience, can be challenged, and more so in the direst of circumstances. Coping strategies are necessary, including self-care and recognizing signs of distress, fatigue, and grief, and seeking help if stress reactions continue over several days. Supportive care and messaging from management is really important for unlicensed care staff to maintain a sense of control and order during the pandemic. Care attributes listed in this slide are ingrained in unlicensed care staff who again are at the bedside of residents 24 hours, 7 days a week. As unlicensed care staff know their residents so well, they truly embrace the care needs of those who are seriously ill and dying, whether it is a resident with COVID-19 or other serious illness or condition. Trustworthiness includes 3 elements: competence, you'll be reliable and honest; imagination, which is the ability to creatively meet the needs of people by feeling with their patients and families. You have an immense amount of imagination to feel compassion, find a way to make things come alive and look well in a time of the direst of circumstances. Beauty is often overlooked. The beauty of patients' humanity is exemplified through active listening and listening deeply. Space may be violated with technology and various other things going on in the room, but you can maintain personhood and all that is good in the people that you serve. And presence is truly being attentive to people, their decisions and values, and with it brings respect and the privilege to care for them during the darkest of times. In summary, the current COVID-19 crisis places older adults at risk who reside in long-term care settings. Unlicensed care staff, you, have a critical role caring for older adults who are seriously ill. Meeting the physical, psychosocial, and spiritual needs of older adults, and particularly at the time of death, is so important. You need to know that the resident in so many ways can be exemplified at the end of life, and attending to those personal care needs are so important. You also have come to know the resident as a person and their individual goals, hopes, and dreams. Excellent communication skills, or being with the person and honoring their individual preferences during times of uncertainty at the end of life, is most critical. Including family members as part of the diet is important, especially during this pandemic. Finally, unlicensed care staff, all of you in part of this disciplinary care team, you are working together, meeting the essential needs of the resident and family while addressing your own personal needs during this pandemic. I hope this lecture provides and stimulates you and provides the resources needed to carry on in your most sacred role. And I wish you much success and wellness in the future in caring for our older adults in long-term care settings. Thank you.